Welcome to a look inside the CBC. My name is David Woodruff, and I am the editor of Critical Care Nursing Made Incredibly Easy. I hope to make this just as easy for you. Let's take a look at our CBC. One of the first components we will notice inside the CBC is the red blood cell count. The red blood cells give the blood its color. When they're oxygenated, they tend to be bright red, and when they're deoxygenated, they tend to be a little darker in color, and that's why sometimes you'll see us estimate or assume that blood that's deoxygenated, in other words, venous blood, is blue. It's not really blue. It never turns blue, but it's just a darker red in color, and so we often use that coloring to help to be able to visualize what venous blood would look like. Red blood cells are produced in the bone marrow, and then they go out into the bloodstream, and they circulate there, carrying oxygen and carrying CO2 away. They last for about 120 days. So you can see the lifespan of the red blood cell is not very long. In addition, as those red blood cells are starting to age out, so they're starting to get older, and they don't carry as much oxygen. Now, we don't know which red blood cells in your body are at what age. There's going to be some that were just born a minute ago, and there's going to be some that have been rolling around in the bloodstream for 119 days. You don't know which ones are which, and hopefully those ones that are still at 119 days are working fairly well, but it's likely that they are not working as well as maybe some of the newer ones that are being put into the bloodstream. So we can have a variety of different characteristics of the red blood cell and its ability to be able to carry oxygen and CO2. What this diagram here is illustrating is it's also illustrating that important component of the hypoxyhemoglobin curve, which is that oxygen must bind to hemoglobin in order to be carried through the blood. We do have oxygen that is dissolved in the blood as well. Okay, so when you look at a blood gas, that's your PO2. But most of our oxygen that we use at the cell level is going to be what is bound to hemoglobin in that combination there of oxyhemoglobin that we see in our picture. Erythropoietin is very important in the process of developing new red blood cells. Erythropoietin is stimulated by having a low oxygen concentration. So let's say that you have a patient that came into the hospital, and this patient is having some kind of a crisis. Maybe they're having an acute respiratory condition of some sort. They were in a car accident, they have a pneumothorax, and they have an acute respiratory condition causing a low oxygen concentration. Now remember that it takes a while for red blood cells to mature, so they're produced in their bone marrow, and they have to mature in the bone marrow. They go through about 6 stages of maturity before they come out into the bloodstream. So this is not going to happen like, boom, overnight. We've got a low concentration, and then, boom, we've got more red blood cells because of that low oxygen concentration. But erythropoietin will be stimulated by the kidneys when the oxygen concentration is low, in an effort to increase our oxygen concentration to a higher level. In some cases, though, we may have a normal red blood cell count and still a low oxygen concentration. Can you think of some situations where that might occur? How about in a patient who has COPD? And they have a chronically low oxygen concentration. Their oxygen saturation is chronically 88%. And they walk around every day with that. They're fine with it, no problem. So they have a chronically low oxygen concentration. Therefore, the kidneys will be stimulated to produce erythropoietin. They will stimulate the bone marrow to produce more red blood cells. And in our patients who have chronic respiratory conditions, we often see that they will have a red blood cell count and hematocrit that's higher than normal, or at least on the high side of normal. Now, the important component of our red blood cell, as far as carrying oxygen is concerned, is going to be the hemoglobin. And one important component of hemoglobin is going to be iron. So we need to have iron, and there needs to be iron in the diet, to be able to produce enough hemoglobin to produce enough red blood cells and therefore to be able to carry enough oxygen. Now, we can produce red blood cells that don't have a lot of hemoglobin in them. We'll talk about that here in just a minute. If we don't have enough hemoglobin, though, in our red blood cell, it's not going to carry as much oxygen as it should, and we'll end up having an anemic type of state. I'm just going to briefly tell you about the rule of threes here. We have another video on the rule of threes, so feel free to take a look at that one if you want to know a little bit more about it. The rule of threes states that normally the red blood cell count, if you multiply it by 3, it should equal the hemoglobin level. The hemoglobin level times 3 should equal the hematocrit level. So for an example, let's say that your hemoglobin was 10 and the hematocrit was 30. Hemoglobin times 3 equals the hematocrit of 30. Okay, that's normal. That's what we expect to see. We can also use this formula, since that's normal, we can use this formula to help us to figure out whether our patient is dehydrated or overloaded. Okay, well, you may say, oh, geez, all I got to do is look at their I&O. I mean, come on. I don't need to look at their H&H to find this out. Well, in some cases, we do. Maybe your patient is tachycardic after surgery, and you don't really know, well, geez, do they need more fluid? Do they not need more fluid? I don't know where they're at with their fluid status. It seems like they're getting good urine output. It seems like they're getting enough fluid in because they have an IV. Where are we at with this? Okay, well, take a look at the rule of threes. So if I were to plug in, let's say, for example, that the patient's hematocrit is 30, but their hemoglobin level is 7. So I take their hemoglobin level times 3 equals 21, and then their hematocrit level again was 30. So the 30 is bigger than the 21, indicating that the hemoglobin is rather concentrated and the patient is dehydrated. Okay, again, so if you want more explanation about this, feel free to take a look at our video about the rule of threes, and we'll do some more examples there. But let's talk about our red blood cell indices. This is another way that we can evaluate our red blood cells. As you saw before, the red blood cell is made up of heme and iron, and those things will help to develop the red blood cell as far as carrying oxygen is concerned. There's also proteins and other components that make up that red blood cell. And if that red blood cell were not functioning in a normal way, so maybe it wasn't produced in a normal way, or we have some kind of bone marrow disease or something like that happens, then we can end up having a red blood cell that doesn't look like a normal red blood cell. There's two main things that can happen to the red blood cell that could cause it to be different. It could be different in color, it could be different in size. Let's start with size first. A red blood cell could be too small. Maybe the patient has some kind of nutritional deficit, and that nutritional deficit is setting them up so they're not able to develop well-formed red blood cells, or they have a bone marrow disease that's causing that. On the other side of the coin, we can also have a red blood cell that's too big. Geez, too big. Doesn't that sound like a problem we'd all like to have? I want to have big, strong red blood cells, right? But if that red blood cell is too big, it won't fit through those tiny little capillaries where we need it to go. So that's not necessarily a good thing either. And what usually causes a red blood cell to be too big is that it's taking on too much protein. It usually does this in order to be able to compensate for other things it's supposed to be composed of. So maybe it's missing some of its components. Instead, it takes on additional protein. It becomes too big, and then it gets down there into peripheral circulation. It gets stuck, and it causes, potentially, venous thromboemboli. As we take a look at the color can be just right. It can be too dark or too light. Again, too dark, Now, first of all, what's causing the color? The color is caused by the amount of hemoglobin that's in the cell. Well, geez, too dark, and that means there's more hemoglobin. Again, we got a big, strong cell with lots of hemoglobin in it, right? Okay, but that's not a good thing again, because if it's too dark, then we're going to have a bunch of hemoglobin that's not being used, and that's hemoglobin and iron that could have been used for another cell that was more productive. So we may end up with a cell that has lots of additional components that it can't use. On the other hand, if we end up having a cell that does not have enough color, that means it doesn't have enough hemoglobin and won't carry as much oxygen. So on either side of the coin here, not enough or too much, we are having a situation where we're not carrying as much oxygen as we would like to. Okay, now let's put these into terms that we often see with red blood cells. So the color, we call that chromic, and we would have a normochromic type of cell, or a hypochromic, or a hyperchromic cell. The other point of view is to say cytic is the size. So we can have a microcytic or a macrocytic cell, or a normocytic cell. So we want to have a normocytic, normochromic type of red blood cell. Normal size, normal color. And that's what our red blood cell indices tell us, is the size and the color of the red blood cell. So let's take a look at this chart here, and the values you're going to look at on your red blood cell indice is going to be MCV and MCH. MCV stands for mean corpuscular volume, that's size. MCH stands for mean corpuscular hemoglobin, that is the color. If you have anemia, and both of these are normal, size and color is normal, but we have anemia, it's from blood loss. Well, that makes sense, right? I mean, the cells are fine. There's nothing wrong with the cells. We just lost them. We don't have enough. If we have anemia and the size is too small or too big, but the color's okay, that would indicate a chronic disease. If the size and color both are too low, that indicates an iron deficiency anemia. So the way we use this is we look at our red blood cell indice, we look at our MCV, our MCH, and if they're both normal, the anemia is caused by blood loss. If they're both low, it's iron deficiency. Everything else is a chronic disease state. I hope that makes sense. Well, what about a lot of red blood cells? Gosh, wouldn't that be a good thing? And again, let's talk about that COPD. He may have a high level because of the overproduction caused by the chronic erythropoietin stimulation because of a chronic hypoxemia situation. Well, the problem of having too many red blood cells is that it's going to tend to cause circulation to be sluggish, way out there in the periphery, and it could cause clotting to occur. So we can get some microclots happening out there in the peripheral circulation, which would further decrease oxygenation to those tissues. So we really want to try to avoid dehydration in these patients because that could, again, add to the problem of having this sluggish circulation and the potential for clotting. Another component of the CBC is going to be our white blood cell count, and here are some of the different kinds of white blood cells that we count in our white blood cell count. Neutrophils. Neutrophils are the most prominent type of white blood cell. Lymphocytes, the second most common type, followed by, in smaller proportions, the monocytes, the eosinophils, and then our basophils. So this diagram here illustrates what we see as a result of having an elevation or a decrease in each one of these specific cell types. Now, certainly we can take a look at somebody's white blood cell count and say, oh, their white blood cell count is high. That would indicate an infection. Well, maybe. It indicates some kind of inflammatory disease, probably. Or we can say, hey, the white blood cell count is low. What's going on there? But if we want to know where it's coming from, then we need to look at the specific elevations, and that's why we look at the differential. So with our neutrophils, if they're elevated, it typically indicates a bacterial infection. Could be leukemia, could be ischemia, but in most cases it's going to be a bacterial infection. So this is that shift to the left that we often hear about. The shift to the left. Sepsis, cancer, autoimmune diseases can cause a decrease in neutrophil count. Well, wait a minute. Didn't we say bacterial infection causes an increase? How come sepsis causes a decrease? Doesn't it seem like that makes sense? What happens when we get to the point of sepsis, and really we're talking about like sepsis, septic shock kind of thing. When we get to that point, we've used up the neutrophils. There's not enough of them left, and we get a low level. Lymphocytes most commonly elevated with viral infections, and we may see them decreased in patients with immune deficiencies or autoimmune diseases. Monocytes are most often increased in chronic infections and maybe decreased in situations where we have bone marrow damage. Eosinophils most often are going to be elevated because of allergies, could also be inflammation. Okay, allergy causes inflammation, so those things kind of fit hand in hand. Basophils, inflammation and allergy again. Okay, so inflammation coming first with basophils. So, we got somebody here that we don't know what's going on here. Is this an allergic response or some kind of inflammatory response? Let's take a look at the eosinophils and the basophils. We would expect that they might both be elevated in either an allergy or an inflammation. Which one is more elevated might tell us which way to go. Okay, I just mentioned before the shift to the left. Well, years ago, when they used to do these counts by hand, so literally you'd have a guy sitting here at a microscope, and he's counting the different types of cells. When he's counting them, he's writing them down on a piece of paper, and he's writing them from left to right. Well, the first type of cell, again, because it's the most prominent type, is the neutrophil. So as neutrophils elevate in an acute bacterial infection, we would see a shift of the numbers to the left. There would be more neutrophils and less of the other components. Okay, remember they're counting the number of these in an area of blood, and because we have more neutrophils in that area, the other ones are getting crowded out, and we would have that, what they call a shift to the left. So that's what they talk about when they're talking about a shift to the left. What you're looking for is an increase in neutrophil count. Platelets. I think we all think about platelets as being those pretty little star-shaped things that are flying around in your bloodstream. That's an activated platelet. If you have star-shaped platelets floating around in your bloodstream right now, you're getting clots. Okay, so platelets usually are round. So we take a look at the picture at the top there, and you see the platelet, normal kind of platelet-looking thing. It's round, it's soft-edged. It becomes activated, and then it starts looking like a star. As it combines with fibrin, it starts to plug up those holes. So you see down at the bottom there, the platelets are attaching to the blood vessel wall, and they start to, along with fibrin, they start to seal it off, and they cause clotting to occur. But normally our platelets are not floating around in our bloodstream looking like little stars. They're floating around looking like little circles, so that they're not causing clots occurring all over the place. When we don't have enough platelets, okay, when we look at this kind of situation and we say, geez, the patient's got a low platelet count, I wonder why. Well, in most cases, the reason why the patient has a low platelet count is going to be because they've used them up. In situations like sepsis and surgery, we're using up platelets. We have inflammation occurring in the body, and the platelets are being used in order to try to form clots and heal parts of the body, etc. When we have a really low platelet count, It could be caused by a situation called ITP, idiopathic thrombocytopenia puria. Alcoholism, DIC, again, we've used them up. Diagnostically, we're looking for gross bleeding, and this picture here is illustrating somebody with lots of petechiae on his back. So we're looking for those petechiae. Those are just tiny little blood clots, tiny little bleeding spots that are occurring on this patient's skin. IV sites might start to bleed. The GI tract might start to bleed. Okay, we can get some occult bleeding that's occurring, so we start to see some melena in the stool. We want to correct the underlying cause of the deficiency. So if the patient has sepsis, let's treat the sepsis. Let's treat the infection. Patient's had surgery, it's going to start to improve. We usually don't do anything other than monitor the patient, unless the patient's got gross bleeding, then we start doing some platelet transfusions. But we don't usually do a lot for a low platelet count that's transient. However, in situations like ITP, we may have to give corticosteroids in addition to our platelet transfusion in order to be able to get that level up and keep it up. In ITP, what happens is the body is attacking the platelets and killing them off for some reason. It's an autoimmune thing. Thrombocythemia is a situation where we have too many. Okay, this is usually a rare situation. We usually don't form too many platelets, and platelets don't have a very long life cycle, so they're not going to stick around very long anyway. But it's usually a transient kind of a thing, maybe as a result of a person who's had trauma or surgery, and they've overproduced platelets for a period of time. If this is a chronic kind of condition, though, then we may have to do something like a platelet pheresis or myelosuppression in order to try to decrease the formation of new platelets. Well, thank you for joining me for a quick look inside the CBC. I hope you'll join me for more videos and check out our website at thenursingprof.com. Until next time, bye now.